Okay, folks. Already we've had a intensive short-term therapeutic intervention, and the address for getting Alan's PowerPoint is posted on the screen there. So by the time we're finished discussion with Alan and Scott, that should give you time to write down that lengthy URL address, and you can get the slides at your leisure. They'll be posted on the IIB website for a week. So I flipped through the questions and I picked one to start with, and then that'll give me a chance to flip through the rest of them. How does the therapist provide a safe container in these two different approaches? Oh, whichever of you would like to take that one on for starters.
In the, I think, fair to say in all psychotherapy, but certainly in ISTDP, the effort is to establish a sense of partnership with the real human being who is in the room somewhere. And in ISTDP, defenses are identified and challenged. I didn't really go into much to do with the technique, but there is a tremendous focus on identifying and challenging defenses. It never is productive and can create a misalliance unless there is a clear mutual knowledge that it's not the patient who is being challenged or criticized, but rather it is the dysfunctional character logic patterns and defensive patterns that are being challenged, and that the therapeutic alliance is the real person, the suffering patient, allied with the therapist to mutually deal with the self-destructive patterns. So with each person, that would take different kinds or amounts of work to establish that. If you have a person who is projecting, if you have a person who is imagining and believing that the therapist has critical, negative, judgmental, rejecting attitudes and so on towards the patient, then clearly this needs to be identified early in order to clarify this and undo this and create a possibility of a therapeutic alliance. Those are some things that I can think of to say.
I appreciate the phrasing of the question. I think it really is a significant way to put it, and that is I can make an environment safe. I cannot make a person safe. Psychotherapy is an intrinsically unsafe activity. Who of us expects to walk into a room and be confronted with ourselves in some unconscious manifestations and expects not to feel uncomfortable? So really what we're talking about here, and I think Alan puts it very clearly from the standpoint of what's on the outside of the therapist, and all I would add is what is required for me to be a safe person to be with? And from my point of view, and this is what I wrote in this most recent article, what that requires of me is to relinquish the center of the relationship from the moment the contact is made and then on into forever, basically. It's a completely artificial relationship whose purpose is to keep the patient person at the center and that person's welfare a priority, and I'm obliged to do whatever it takes, including encounter myself, to make that possible so that the operations that Alan just described can be accomplished.
Thank you. Does having a positive resource, a good therapist, a good partner, help give micro experiences that add up to the beginning of a more sustained core self? And this is a question for both of you.
Well, I'll carry forward from the last question because I'm talking to therapists, and this is not a self-help program. The answer to that is maybe. Maybe. The problem is if the therapist invests that that should happen, then that becomes an oppressive, re-traumatizing expectation that good interactions should produce structure. The first paper I wrote on borderline structure was called Living on Shifting Sands. You can't build with sand and water. So the answer to that has to be in the body of the therapist. This is a good thing in the world. It might help you. And if it does, we'll build on it. And if it doesn't, we'll understand why not.
And just to add a little bit to that, so I think we try to very often and very regularly check in with a patient to within one session and ongoingly about whether there's improvement or whether there's actually the opposite, and not make assumptions that what we are doing is necessarily the right thing or good for the person, but to actually have interaction about whether things are actually improving, and if so, what and how much. And the question that was asked was about establishing or creating more of a core self. Obviously, that's a really tough and deep question, but regarding any manifestations of that that could be mutually understood to relate to that, then we would be making an effort to try to track that as time goes on. However, with the extremely important and deep proviso that Scott just said, which just pervades all of psychotherapy, which is the issue of our investment into having the person improve, and how from our good intentions that can end up having negative consequences on both of us in the interaction and on the relationship.
I want to follow this because this is, to me, a very important issue, because I'm already having the fantasy of people, you, or prospective patients saying, well, isn't something supposed to happen in this therapy? Aren't I supposed to get better? I mean, isn't there something? And I think each of us is really required to identify the core value that we're working with. Because when patients ask me what it is I'm doing, what I say is I am working to facilitate a person's experience of themselves as deeply as they can and want to feel themselves. So I'm interested in the continuum between unreality and reality. And so someone who wants to feel better may or may not work so well with me. And I may miss the moment when I ought to say, oh, that's a good thing for you to do. And I'm not a good match for that person in that way.
Yeah, that's, I do tend to take a different position about that, and that is that I do feel that it is my responsibility to help and not harm, and that I do not take the approach that this is an open-ended exploration. If the person's depression is getting worse, even though they're learning more about themselves, or their anxiety is getting worse, even though they're understanding more about their childhood, then I don't want, I feel a responsibility that that's not what I want to allow to continue to happen.
There were quite a few questions that came in around that same theme. So a question here for both of you is how do you balance working cognitively or discussing with somatic work, working at a somatic level?
In my kind of work, there is a ongoing back and forth between the cognitive and the experiential. In Davenlou's original conceptualization, there is a pre-interpretive phase and an interpretive phase. The pre-interpretive phase is that before there is any powerful emotional experience that links with the formative past, there is supposed to be no interpretation, no talk about, well, it's, you know, because obviously your mother was like this, then we can see probably that this is like that. Those kinds of kind of stereotyped psychoanalytic interpretations, theoretically linking the past and the present, are not made. In fact, in our work in general, we don't inquire about the past at the start. We deal with here and now, what's going on right now. After there is significant emotional experience, non-intellectual emotional experience, with linkages to, experiential linkages to the past, then interpretation or cognitive work is used in order to bring understanding about the patterns that have happened in life and how they relate to the present. On the other hand, so that's one thing. However, on the other hand, in the process of restructuring, like restructuring ego fragility and so on, there is a lot of back and forth between cognitive and emotional work. So a feeling is like a graph. A feeling is brought towards the surface, and we use observation to try to determine just before the point that there starts to be cognitive perceptual disruption. A feeling is encouraged at a very low level. And as that threshold starts to be reached, that cognitive perceptual disruption starts to be about to happen or maybe starting to happen, then we back off and we use a lot of cognitive work to understand that. Do you notice that when we were talking about anger at your wife, your anxiety started to rise, and you started to have some sense of that anger, but yet your anxiety started to rise, and you started to have a little bit of blurriness of vision. So that is a severe anxiety symptom. So obviously, experience of anger starts to create huge anxiety inside of you. And so it goes on with backing off from the experience and using the power of the rational mind and the observational capacity to start to integrate this. And then with this process, then the next time that something like that is worked on, then the experience of the anger can start to be brought a little more strongly to the surface before there's cognitive perceptual disruption. So the back and forth process of emotional experience with cognitive integration is used in the restructuring process.
The first thing I'll say about this is that I'm a thoroughgoing bioenergetic therapist, so I don't use a dichotomous language. There are no differences here. I'm in an energetic soup of process. That's fairly threatening, by the way, if we take that seriously, that the patient and I are in a semi-merged state or some kind of open energetic field, and it doesn't really matter to me at what level our communication is taking place. So I appreciate Alan's technical distinctions. I work with a patient I've worked with for many years who first came to see me because he was stopping at every payphone and calling one of his parents and screaming on the telephone out on the street. And we've worked very deeply for a long time, and eventually he developed a discrete behavioral symptom, which I have a lot of information about because I have the symptom. And he decided that he did not want an exploratory way of dealing with that symptom, and he began to see a cognitive behavioral therapist, and she and I have talked to each other, and he's consulted each of us. I'm pretty sure that the underlying material of that symptom is not available for explanation. I would talk about it in terms of explanation rather than cognitive function, and not linking by interpretation just to make the causal connection. But I find that I and my patients need explanations for things. The problem is explanations are not assimilatable until I have a certain level of structure and competence with myself and emotional, psychic, and cognitive materials. So from a technical standpoint, I think we're probably not that far apart in that we titrate, we adjust ourselves to what's available to the person.
Which is a wonderful point, that you can read all different types of psychotherapy and their theories and so on, but seeing actual therapy or experiencing it or seeing video, audio-visual recording of therapy, sometimes these seemingly huge theoretical differences melt away, and you say, well, whatever you call it, you know, that's not so different than what I'm doing. And so, you know, seeing these things in action is different than talking about them, obviously. However, I will say, in addition, so I talked about the different systems of resistance, with isolation of affect being the most healthy system of resistance. This involves the capacity for intellectualization, rationalization, and so on, higher level defenses. So when a person has primitive defenses, we work to try to replace the primitive defenses with more higher level defenses. So we try to help a person who uses splitting, projection, projective identification, and dissociation, and so on. We try to help that person to become a more regular neurotic. And this is, on the one hand, I was purposely humorous, but on the other hand, it's true. I mean, this is the idea, to become a more regular neurotic who can contain affect and use intellectualization and rationalization and use the cognitive rational mind to contain the emotional system. And then there is that full container, and then there is the capacity to go deeper into the emotions, and then there will not be an overwhelm.
Yeah, I think this is a really important point to me, and might be a place where there's a difference in substance, not just between what Alan and I do, but between what some of you and I do. And here's how I understand that. I remember very well the experience of laying on the floor in Vivian Guz's office after years of very active work and taking a breath, and for the first time realizing that my lungs were no longer adhered front to back together. I could actually inflate. This was years of therapy. So when we talk about breathing, we have to be very clear that taking a breath at this point in my life is an entirely different experience than it was at that time in my life. And so if we work on the premise that now you're breathing more, and therefore you can perform certain somatopsychic functions, like use an ego container for your deeper experience. There's some truth to that, but it's very different from the way it's going to look, at least with someone structured the way I am, much later in the process. And so building a more neurotic person, which I understand as a concept, and there's some necessity for that, because how else are people going to come to an outpatient psychotherapy if they can't get through the week and pay their bill and so on and so forth? Requires, at least from me, a recognition that at the same time there's another version of this person with whom I'm working at a much deeper level, and I have to be prepared to descend to that level, descend if that's the right word, to be at that level with them and not expect them to be able to perform functions in the process, in the psychotherapy process, that they cannot yet do.
Scott, with what you were just describing about the breathing. So when I hear that, the theory that comes into my mind is that anxiety manifestations are restricting the breathing. And whatever, experientially, however that feels, and whatever kinds of words how that would be described, but in some way, shape, or form, anxiety is restricting the breathing. And my idea is that by virtue of helping the anxiety to, number one, be reduced, and number two, to manifest itself, to discharge or to stream in a different way inside of a person, would help to change that aspect of the breathing. How does that fit or not fit with your experience?
Yeah, that's you've put your finger on the issue. Let me just say, for background, I want to answer that. That's really important to me, what you're saying. What comes out of Reich and Lowen and all kinds of other theoretical models is the assumption of an already structured self waiting to be brought out. You know, Reich and Lowen, they were utopians. They were Rousseauian, actually. They thought that the natural man is just waiting in there to be brought forward. And the way that relates to what you're talking about, Alan, is that we don't have the methods yet to study this. For example, we don't have the methods to study the changes in the digestive process that occur in profound eating disorders. I have a profound eating disorder, what would nowadays be called a body dysmorphic disorder. It's a psychotic state. I feel like I'm going to expand to the point of explosion. It's energetic. And yes, it's related to anxiety, But in bioenergetic theory, the underlying structure in order to reduce the anxiety to get to a full breath, the underlying structure in the intercostal muscles, in the alveoli of it down at the bottom of the bronchial tubes, that tissue cannot expand. It does not have the structure to actually do the function. So relieving anxiety is what enables me to lay on the floor and try to take the breath, while I feel like some of you felt when you were going down through the floor, but it doesn't make the breath more possible.
Okay. So how do you know it's the alveoli? How do you know these things?
Yeah, this is right. Okay, so the straightforward answer to this question with no embellishment is I started my first psychotherapy in 1966 with a Reichian orgonomist. I found my way to Vivian Gou's for 20-something years. I have not been in a bioenergetic therapy for a very long time, but I've been in a therapy that welcomes my use of interoceptive information, and so the data comes from me.
We don't have sensory nerves in the alveoli.
No, but I have, well, that's an interesting problem, right? But I have a body sense, and each of us has a body sense when we take a deep breath, what that feels like. And at that moment, when I took that breath, it was clear to me that years of work had released some adhesive function. Adhesive was the only way I can describe this. So either I have to give up my sensory information and say that was really a defense against anxiety, or I have to say I know something really deep about my own body that does not conform to what is, by all definitions, and I don't think you're going to disagree with this, a very, as yet, limited understanding of neurophysiological reality.
As Alex mentioned, as well as my psychotherapy work, I also work in addiction medicine. So I have lots of patients who are addicted to opioid drugs. And I often ask them what they gain from these drugs. And if I can get past just some politically correct talk, oh, doc, they're no good at all, we both know that. If I can get past that and get to some experience, people talk about incredible relief of unbearable pain and anxiety. And people talk about such things as, well, doc, I sit there and after I've taken my such and such, for the first time all day or whatever, I can actually take a deep breath. The emotion physiologic researcher Jaak Panksepp, who just recently died in Washington State, he has done research on the opioid pathways in the brain and the reduction of psychic pain. And this kind of reduction of massive psychic pain and anxiety and the kinds of physiologic changes that can immediately produce in a person, I think is something also to consider.
So let me go on with this. To me, this is one of the true differences between the way that I and my colleagues understand body and somatopsychic process, and the way other people who do really good work, this is plainly a lovely man who does really good work, so it's not about that. But we know that a body that is frozen from breathing is different from a body that's collapsed from breathing, or a body that's inflated and trapped into an upheld breath to protect from deflation, and then held up here from a body where breathing is used to prove achievement and accomplishment. That these are not traits, these are not momentary events, these are states of being, and they're structured. Now, structured is a big word, and if we start to break structure down into what are the muscular processes and the neuromuscular processes, we don't have enough equipment yet to understand the deepest levels of this. We don't have enough equipment to understand what happens to the small intestine and the digestive system in what we would call an oral collapse and an inability to digest nutrients, food, love, affection, care, warmth, etc. But we know, because we study this and live in our own bodies, that this body and this body, when they speak of breathing, are talking about very different phenomena. You can't use breathing to go across all those categories.
Well, that got something started, eh? Well, here's one. Yeah, here's one that I think you can do something with. Probably several groups, but this one group said they'd like to listen if you can both share with us 2 clinical vignettes of your therapeutic practice. I think is a way to get some feel for what's this like in action.
Okay, so I'll introduce this by just mentioning a point which but perhaps I touched on in my slideshow and all of that, but so, you know, in ISTDP, the concept is about powerful internal experience of emotion. And any form of even movement is looked upon as a defense against the full experience, because of movement discharges the emotion. And when we are really working intensively to try to maximize the experience of emotion, we are discouraging any movement, which sounds weird, probably, from some standpoints. But if a person is angry, we encourage a powerful internal experience without movement. So a clinical vignette that comes to my mind is a case quite a long time ago, a man from the Maritimes with very, very severe relational trauma and very severe problems. Finally, after some number of sessions, when the experience of anger, this was toward his father, was deep enough, I have it on video, that this guy was sitting quite still, looking to all the world very relaxed, able to describe massive waves of electricity moving throughout his body, speaking of it with wonder. And these waves kept coming and coming for 5 or 10 minutes. They would come and they would subside. They would come and they would subside. Associated with these waves of power, of electricity flowing through his body, were, when I would ask him, massive murderous, torturous impulses toward his father. But to look at the guy, if you saw the tape without the sound on, you would see a guy kind of calmly sitting there, looking quite relaxed. So this is one therapeutic vignette that comes to mind that I just chose to illustrate a point that I think is quite important. I'm not sure how unique it is to the type of approach I use, but I'd certainly be interested to hear how that compares and contrasts with work in bioenergetics. So that's one case.
Well, before I offer you a vignette, I want to say, I want to have some of what that guy's having. If I remember that scene from Harry and Sally, it's like, I want to have what that guy's eating because that would be very useful. It's interesting what first came to mind, which is related to what Alan's talking about. I work with an older man. He had some psychotherapy, some bioenergetic therapy actually when he was younger. Very successful professional man with a very good second marriage, a quite terrible, painful first marriage for many, many years. And he comes out of an environment that is so terribly traumatizing, it's quite amazing that he's gotten as far as he has in life. And he's understood a lot about it. We're back to understanding. And he's expressed a lot about it. And every time he starts to breathe deeply, he starts to spasm and make a very loud, not quite a scream, but a very loud sound. And we've gotten very far with this kind of work where he just does that spontaneously. And in one of our recent sessions, he gets into an experience of wanting to push his mother away. She was very intrusive and simultaneously violated and possessed all his space and abandoned him completely, which is a terrible combination. And he seemed to be making gestures toward pushing something away. So he's anything but quiet. He's laying on my bed. He's having these strong, spasmodic sounds. They could be rage. They could be pain. They have elements of both, grief. And I took a very large pillow and I held it on his hands, and he started to push me away, or whoever was on top. And what happened then was that his rage became organized and focused. It was no longer a diffuse sound. It was now directed, and the force of it was for, well, he's a man my age, so I have some idea of what the force is involved. And now he's got an integration of sound, feeling, content, memory, relationship connection, and for the first time, he's beginning to work in that actual space. It's no longer encapsulated. The violence between his mother and father, the feeling of being a little child in that space, the sense of being violated, it's now becoming an organized, physicalized expression. And that's integrative. So for me, having the space that he can embody that in a kind of whole integrated way is necessary for my work. I don't have a second. Do you have a second?
You're always so impatient.
Yeah, that's it. I'm done.
That's it.
No, go ahead. I'll pick a second. You do another one.
I'm sure you will. Okay. Briefly, so another patient that comes to mind from years ago, patient with severe, whatever you want to call it, 20th century disease, allergic to everything, can only eat 6 kinds of food, like only, 6 different items of food is all she can eat. She can't eat fruit. All kinds of things she can't eat. She gets real and noticeable physical swelling and physical reactions. She's been to every kind of practitioner that you can think of, including major ecological medicine type hospital-based things, all of this stuff. She had no idea that any of this had anything to do with emotions. On tape, I have it that I think it was by the third session, after having worked on the experience and integration of emotion, she came in saying, with a huge smile, saying that she can now eat, that she's tried eating these other foods which she can now eat without symptoms. And as the work went on, that and lots of other changes took place because of the ongoing increase of capacity to experience emotions, including rage, including pain, including love, including sadness, including guilt, without somatizing.
Wow. What comes to me, and I'm going to assume that what's arising in me is both relevant to this event and for me, is a woman, young woman I've started to see fairly recently, who's had quite a lot of psychotherapy intervention in her life, some of it very successful. And I think she came to mind because there's a conventional misunderstanding of active technique that it involves getting people to do things. And I think there's a confusion between containment and restraint. Containment is when I extend my own energetic system in my field to create a holding environment. But frequently, a lot of my work involves restraint. And in this particular case, this is a young woman with a more forceful attachment to me than A, I'm used to, and B, I'm comfortable with. And I would say that one of the issues that I didn't get to talk about borderline and schizophrenic people is that our conventional idea of attachment, when it comes to those structures, is mistaken. The portals, the umbilical connecting points for attachment are not available to people in those organizations. What's available is dependency, which is a pretty good thing when you can't have attachment. Attachment's not available because I can't apprehend the other person inside my own body. I remember very well the first time I had the experience of object constancy. It's when I realized that I could remember then Virginia Wink's face in my own body. She and I were colleagues in the first 4-year training. And so this woman's dependency on me does not feel like an attachment, it feels like a dependency. And I am countertransferentially very challenged by that and how to receive that dependency. And I'm also aware that I'm very carefully keeping my distance and not offering physical contact and not responding to the kind of tidal pull on me to make some gesture of physical connection because I'm not sure what I'm doing.
So you folks up for one more?
Yeah, one more. I have to be some.
So the question is, if we have such a feeling of being unlovable and such an inability to feel benevolence, what force has kept us alive? I think you each talked about people being in this dark place and how your approaches try and reach out and connect. But I think the question has, what's What's keeping this person alive? How do you see that?
So, Scott talked about a utopian or Rousseauian view of humans, that even in the most damaged person, there is some kind of real or healthy self somewhere in there. And he was saying that, if I understood him correctly, that he believes that that's not necessarily the case. In my work, I tend to take that view, that somewhere inside there is some real self, some healthy self. Maybe not fully formed, maybe damaged, but still at least the seeds of that are there. As I said in my slide presentation, the role of the punitive superego is very prominent in ISTDP, namely the role of self-punishing and self-destructive forces. In this work, we, as early on as possible, try to differentiate in a collaborative way the self-destructive forces as distinct from the real self, or the healthy forces, the forces of health, the forces of growth. And that would be in the full spectrum of even the most troubled or damaged people. When there is no capacity to experience pleasure, no capacity for joy, no capacity for love, for attachment, even in the most damaged people, along with anything else I might be doing, I am trying to be on the lookout for the forces of inhibition, the inhibitory forces. My metaphor for this, one of my metaphors is that, if you have a seed, even if that seed does have the potential for growth, if there's a big rock sitting on top of it, it's not going to grow. So a whole lot of the work is focused on removing the rock from on top of the seed, because no matter what you do therapeutically or personally, as long as the inhibitory force is on top of the seed, it's not going to grow. Another metaphor is the computer virus in the computer. You can have a computer that is capable of many things, but if a destructive program is in there called a computer virus, then the potential of this computer, the hardware and the software, won't come to fruition. So the punitive superego, the role of guilt, which I tried to say pervades all kinds of psychotherapy but might be called something else, is very prominent in ISTDP, and distinguishing the inhibitory force of guilt and self-punishment from the healthy self is crucial. And we work very much in the here and now. I work a lot in what the person is experiencing right now, here with me, with full eye contact in this room. And looking at and I also work with, one of my little innovations with the ISTDP is to ask a person, to what extent are you able to enjoy this moment of your life? It's a very profound question, I find. And people think it's a weird question, and they don't know where I'm coming from, and they think, what kind of guy is this asking me such a question? Anyway, how much are you able to enjoy this moment of your life? This is one moment. And people, anyway, the point is that we start to distinguish what are the inhibitory forces that interfere with the enjoyment of this moment of life, that interfere with the capacity for connection. In this presentation and in some of the materials I read, I'm I'm challenged to take in and consider things that Scott has been saying and writing, and the degree to which perhaps there is this factor that there's a true lack of capacity. So this is my challenge. This is what I bring. This is what I will be taking. One thing I'll be taking away from this experience, to be pondering this, reading more, trying to understand this. However, in my work, a lot of my orientation and perspective is that neurologically, there are basic mammalian capacities in there. The capacity for connection is hardwired into the mammalian brain. And attachment trauma interferes with the manifestation of that capacity. My job, as I look at it, is to help to identify those forces that inhibit those hardwired neurophysiologic capacities from coming to fruition.
Before I answer this question, which is a very important question for me to answer, I want to invite you energetically to listen to what Alan just said, not on the level of belief or value, but the energetic force of the hope that he has. The energetic force of it. And as long as that's not encumbered by the requirement for agreement, for submission, for gratification of his narcissistic or oral or whatever the hell needs, just get the force of that hope. Some of you wrote the question, wow, what is the hope here? That's what sustains the therapy. Now, I would say, in answer to the question, I have to answer that in two different parts. In the living death part of life, in the cocoon, in the lost in the vampire part of life, life has its own force and carries a person forward with the help of substances, with the help of belief systems, whatever. The much harder question from my point of view is, once awake and alive and in contact, how does one live with the reality of, at the deep level, in the inner body, at the deepest level, where in my body there's an empty chute made of granite with a cold, hard light inside it, and where malevolence abides, among other things. Actually, it does not abide. That space is empty. And then there are surrounding layers. One of them is malevolent. How does a person live with that reality day in and day out? That love and warmth and compassion are not available as sensory felt experiences. And my answer to that is what I wrote to all of you, and in a way it agrees with something profound to me, profound that Alan said, which is, I have an aspirational self. I have a self who I want to be. And I bring myself as close to that self as I can be, and I follow the internal layers. There's a middle layer of my body from which those kinds of behaviors and feelings can now, after many years, be organized and expressed. And I live with the underlying burning that's underneath that, and I bring myself to the edge of the membrane that separates me in that reality from this reality, and I press up against that membrane as hard as I can. And then I have the astounding, immense good fortune to have people who come up and stand right at the other side.
And we could go on, but our time is up. So could you please welcome these two wise people and shower them with your praise and what they've given us.